instructed patient per doctor to take 2 aspirin and call him in the morning,
Ideally, there's going to be documentation in the record where he's confirming what's going on, particularly if the patient is calling with something where there's an onset of symptoms. Now, if the patient calls and it's just a matter of a routine refill and there isn't a new complaint or an exacerbation of symptoms that needs to be clinically analyzed, then doing exactly what you're doing is fine. So it's a matter of being able to assess whether or not any clinical decision-making is occurring. So
one of the big decisions that we have to make when we take calls is whether or not the patient needs to make an appointment. That's one thing they always want us to help them with. They're calling in with a symptom, with complaints.
They're concerned,
do they need to be
confused.
seen or do they not need to be seen?
Yeah.
And where does that, I'm having a hard time with when does that cross the line of us saying, yes, you need to be seen, no, you don't need to be seen?
Well,
that's a clinical decision, right?
It is on the borderline.
Oh,
and I guess
okay.
part of it depends on, and I'm sorry that I'm saying on the borderline because I just said you can't. But the reality is, and you know this because you talk to patients, that there are those situations. The risk of that interaction is somebody calls and says that, it's really been hard for me to breathe when I stand up, and, I'm not sure what's going on. And, you say take ibuprofen, and if you're still feeling bad, that would not be a good thing. They end up in the emergency room with chest pain and, admitted for a full workup. The risk is when you tell the patient not to come in. So the getting a description from a patient and telling them to come in is less risky. That's a huge, long non-answer. But what having a protocol or a policy and procedure in your mind will help you with is what kind of symptom is that coming in, and is it a symptom that could lead to something really bad? So is that something I need to move up the line to somebody who does have the legal capacity to make the clinical decision making? So the policy and procedure is not intended to be a list of always do this and always do that. The policy and procedure is to help you identify at what point in the information collecting process are you comfortable that you are not engaging in more advanced clinical decision making. Does that make sense? The important part of the policy and procedure in that case is knowing who to talk to next. And it's better to take a few minutes and confirm with somebody else than not. And as those situations come up, you're able to build a knowledge base that will allow everybody to handle those conversations more consistently, which is the patient safety issue and the quality issue and the efficiency issue that is important. Are there any other questions? Do you guys do any after-hours call, or does that go off to a service?
It says a phone number. It should say a phone number for the doctors.
Provider is
On-call provider.
It goes directly to the
Oh,
provider.
it goes directly to the provider, not to a service?
Well, you can leave a message, a voicemail, or you can page a provider to call you back.
Wow.
Or call a cell phone if it's emergent.
That's really excellent. So a lot of this isn't going to be an issue. So I've used up most of my time. I really want you guys to ask questions of me, of Deanna, of you, each other, because I think that this is really important. It's important from a liability perspective. It's important from an efficiency perspective. And since you guys are looking at a future of being certified medical assistants that are actually respected and recognized by the state, this is something that is going to become even more part of your professional lives. So ask.
Just questions. I know you guys probably have a million questions because this is all puts it right on the fence, right? With knowing when to go higher and when to not. And what would be one of your main considerations for not taking it higher?
By the way that I'm hearing that, and I'm sure a lot of people are thinking right now, it looks like about 75% of what I do needs to go higher.
Yeah.
I'd really like to know who's supposed to do that. And when I need to start looking for another job, that's how I'm feeling right
Never.
Yeah.
now. Just saying.
Well, that's what it seems like, so.
So Kathy and Denise and I had a long talk the other day, and we went round and round and round about this too. As next year in 2013, when you all become certified or licensed, there are new criteria coming out that will be associated with that scope of practice. So that will probably increase it a little bit, but even there's some consideration as to what an LPN can do and what even an RN can do. So it's not black and white, and that's the toughest thing here.
It isn't.
So is what we're doing now going to come back and bite us in the behind later? Because, I mean, it kind of sounds like we're covered as of 2013, but right now it's limbo.
The issue really is how you're documenting it. So if you're able to use the SBAR and document what you took in, who you conveyed it to, if there's a clinical order attached to it after you've gotten with your physician or the PA or whomever, having some way for them to go back and document that, yes, they really did do this. That's what's really going to help.
One of the things that I've shown a lot of you, either individually or I've gone over with the leads, is the dot note assist, especially the Bonnie Lake people should be familiar with this. And under the A part, under the assessment part of the SBAR, that's where I'd want you to probably put this note assist. And how many of you even know what I'm talking about?
Don't know or no?
Vaguely.
I can say I'm on the phone all day and I haven't used it.
Okay, so why not?
Because typically refill stuff, I have a question about this medication. I have looked at it and I've tried, but it doesn't apply to when they
So
call.
most of what you're getting in is scheduling refills.
Or,
Right.
results for whatever it was.
Right. So on the phone, people are mostly calling in with questions that are more administrative. That's what you're
Good
saying.
point, yeah.
Okay. But Goldie, you're saying that the questions you're answering are more clinical.
Yeah.
And
So because they get these calls, then I call the patient, and while I'm on the phone with the patient, they bring up all this, other. But I was wanting this medicine because that becomes more of an issue.
but then you're discussing that with Dr. Stout, right?
Yeah.
And then they're relaying information, and your question was appropriate. Then can I sign those off? Right.
Do they have to start signing, double signing it?
I'm just saying, my doctor generally has, around 300 on his desktop. He is not going to be
This
having
is a big issue.
Well,
Yeah, I know, and I expected to get this, and I understand. And I'm very frustrated with the state that they've had the rulemaking in hand that would give you scopes of practice. And when you read the bill, it's 25 pages, but it's not rocket science, hard to understand. And the rulemaking is taking a long time. And I acknowledge that. I think that Washington's been backwards for a really long time. Most states do have some recognition of the training and the experience and the knowledge that you have. But as of right now, and in this is actually a document that was okay. In this handout, there's actually a document that we did submit to the Department of Health for review, and the FAQs are also on the Department of Health website. As of right now, until they finish their rulemaking, MAs do not have a scope of practice, and when you ask the Department of Health, can they engage in telephone triage? 3 characters, NO period. And so what I'm trying to do is help you understand what you can do in a way that is going to still allow you to help the patients the way that you are helping, but that is also protecting the practice by documenting the interaction and the decision-making that's taking place on the part of the doctor. So there's no easy answer to it. And I think that Deanna and I think that everybody who works with the system, if they come together may be able to find a workflow that will allow you to handle that without referring 70% to a new documentation level and still demonstrate quality, efficiency, and patient safety. So that if somebody comes in and makes a claim, a review of the file demonstrates that the doctors weren't just letting people do things, that they were actively involved, and that you were actively involved in assuring the safety of patients when you help them out. Now, the note assist.
The note assist, it's, Dr. Aversa created a help called Dot Note Assist. Then I know that the leads are all familiar with this. I know that many of you have been instructed personally. As Stephanie said, she's tried to use it, isn't using it effectively, but where it would go, where I see it get used the most, if you're using the SBAR format, which it's helpful to use and helpful to gain information, those of you who are on the phones a lot, is under the A part of it. The Note Assist pulls in things that help you assess where the patient is. It assesses their protocols, it assesses their med list, it assesses, you know, their problem list. And so I've put it out once, but I'll put it out again, how to access that and how to put Note Assist, and you can actually put it in an SBAR format if that would work. And that's probably the best way to use it. And you can also delete it, whatever's not applicable. So you can put it up, pull it up, everything can come up, and then you can just, you know, highlight and delete, and it all goes away for you if you've just used it to assess. But the providers are wanting to know what data you've looked at, so that when you come to them with a question, that you've assessed the data, not necessarily the clinical condition of the patient, but you've assessed the data available to you so that you can help them make the decision in the most efficient way possible. Okay? Even if more stuff ends up on their desktop, if they can quickly look at it and say, yeah, it's all here, and then I can just make a quick decision, yes or no, or give them this, without having to research it because you've done that piece for them, that's what they want.
Right. Typically what I'm hearing from providers when we talk about things that are hitting the desktop, it comes down to, it sounds like to me that it comes down to things being kicked off too quickly to them, where they then have to go back and look at the last visit and see what the plan was, or, you know, when the last prescription was, and get information that the initial caller should have and could have compiled in that SBAR note to allow them just to look at that note, make a decision, and move forward. And so I think, you know, if we're able to offset some of these other things by ensuring that we, with all those calls or interactions, that we get that information to them, so they're just having to look in one place, be able to make a decision and move forward, then, you know, I think we're freeing up the time to then, when they have to go in and there is an assessment and a plan and whatever the other components of the triaging were, then it's okay for them to go in and sign that, because we're now alleviating some of the other work that they're having to do that isn't necessary.
And it's information that I would guess you are all gathering anyway. So, you know, you might as well demonstrate how much you actually do for your patients.
Denise, part of the SBAR training, it was relayed to the inmates that they do the situational, the background, the assessment and recommendation. The providers, Dr. Aversa and main one, had said they can approach them in the hallway, get the assessment and recommendation, and document that for them. Then that way that phone note wouldn't have to go on their desktop, is what was specifically said in an in-service here. So are we saying that's not the case anymore, or are we going to go back and talk to the providers?
Well, yeah, I wouldn't say to change what's in practice right now immediately if it's a huge change. I would say that, you know, maybe we need to take away, talk to the board, probably not just Dr. Aversa. But, so, I guess to me, I think if it were me and I were having a hallway conversation with them, what would be the harm of standing in front of a computer and having them quickly sign off? Just put the note in and have them sign. If you're having the conversation, can it be
It's
done
patient care.
Wait. How many of you in your documentation would write per Dr. So-and-so? Okay, that's a verbal order. We can take a verbal, can't we?
But we can't
Well,
sign it.
licensed practices.
Licensed healthcare
Licensed people
providers
can take
can.
a verbal, but not healthcare providers.
The way I'm
Not
gonna,
assistant.
You can take that information, you can document it, but
But
at
then
some
he's
point,
supposed to confirm
he's
that.
supposed to confirm
So
it.
then, basically, though, what has been the practice has been to say, per doctor staff, patient is to do blah, blah, and why, and everything, and then sign it, take it off, instead of putting that document on his desktop, for him to have to go through, read it all, and then sign it off. And that was what was taught during the SBAR training, was that hopefully that would alleviate even the signed phone note coming to their desktop. So that's why I want to clarify.
Yeah,
Make
this is
sure
a,
we
this is a big issue,
Yeah,
and
so that's, I
Well,
that's,
I don't know the volume that we're talking about, but it kind of makes sense to me. And if we could find some way to categorize things so that when they open their desktop and they go to work their stuff, they can quickly identify those things that are conversations that they've already had with you guys, and just quickly look through and go, yep, sign, yep, sign, yep, sign. Rather than having to dig back, you know, or sift through everything that's on their desktop and then identify, okay, no, this is a new call I haven't talked to Goldie about. This is a call or a patient that presented that we did call.
I was just going to say, a lot of times when, especially different doctor, like Dr. Blackburn or some Dr. Sennett, I take a note and I'll, her Dr. Sennett, but then I'll put phone note routed to Dr. Sennett for final signature. And he knows that. He just needs to sign it off.
Right, what I'm saying though is when they look at their desktop, that phone note, until he clicks on it, doesn't really stand out.
right, and the way
there-
you could do that is in the
Kept
summary.
separate.
Yeah.
You could do that in the summary. One of the things that we did, that we're doing up on the third floor is to, well, that's on a desktop, yeah, but the same thing could happen in the summary if they put some
Asterisk next to it.
an asterisk or a, you know, a D for discussed already, or whatever you want to, whatever.
Isn't that typically what we're doing already though, to a point with like follow-up office visit or whatever it is in the summary? Isn't that
Right, but
typically
what we're trying to do is give them an indicator that you've already discussed that with them, so they can
Right.
quickly just sign it off without even reviewing it.
and
Nominal.
now,
Without
Nominal
reviewing
review.
it
Okay, you didn't hear.
in depth.
Without,
Well,
without
through the whole
spending a
chart.
lot of time in the document.
it's going to be a brief review and confirmation as opposed to digging in
Right.
and reviewing it as brand new
We used to
information.
call that RNS, review and sign, at the other place I used to work at.
Oh, RNS.
RNS.
How do you guys like that?
I had a folder, it wasn't electronic, but I had a folder, and it was RNS, and he'd have to review and sign. It was all the stuff that I caught in the hallway and talked to him about. So it's the same thing, it's just electronic, review and sign.
A lot of times what I have done is when I want a provider to sign something and I want to make sure there's a second signature on there, is I'll sign it myself but still route it to them upon signing it myself. It still shows up on their desktop, but it shows up that I signed it.
Can they sign it again? They can't.
They can sign it again?
They can't dot sign it, but they can sign it.
Oh, and what does that do?
They acknowledged it.
Yeah, that works.
So see, I think we can,
Yep.
you're already coming up with ideas where,
but then another issue that comes up is you have those providers who don't even want us to have the OBS issue, you know, the documents, the OBS documents that come through that say,
Right.
patient did a mammogram. They don't even want to see those on their desktop, so.
but the difference between that, Jackie, is they don't need to see that. That's crap coming up, that stuff. There is a difference there.
Yeah, there is a difference. It's just making sure that those providers that have those specific things they don't want to see.
And that's what I'm saying, if we can maybe improve the level of information that we're giving them and save their time on that end, then they'll have a little bit more time to go through, and they should be reviewing the notes on the patients that have been in or that have called They should be, but we need to make it as simplistic as possible for them so that it's right there in front of them. They know this is a conversation I had with you, quick review sign, and if it's not a conversation I had with you, then you've presented the information to me, so it's going to take me less time. I have to do less research, because just like we have to go back and look at the last visit, you know, and make some assessment of the situation, they have to do the same. You know, they're not going to recall that any better than we would know that. And so that's what I'm hearing, is that when we take the note, if we could just kind of pull that information forward to them to make their assessment decision making quicker, then we'll free up the time to do this other quick sign. Then we just have to find a way that they're able to identify those easily, you know, and know that I just need to do a quick review and kind of confirm, yeah, I talked to Goldie in the hall.
It seems super risky though to leave it closed. Like if we close it, then they can just delete it. Like
What's
if we
that?
leave it, if we sign
it
and then route it to their desktop, they can just hit remove. No, the doctors that we work for, versus if we be able to open, they're required to at least make some action.
So you like the RNS?
Yes.
Yes. Okay.
If they have to, you know, if they're dot signing and then routing to somebody else, that's fine. If they want to leave it open, but if they want to close it, they close it.
Callie?
I sit on my desktop in front of my computer, and Dr. Conwell goes, yes, this is what you need to do, write this in the chart and sign it up. She sits there, looks at every single thing, but she's not going to try to type on the thing. She wants me to.
But in a court of law, if anything came up, how would that look? There's no official, her signature's not on it anywhere, and she would have to back you up to say, yes, I did that.
I always write for Dr. Conwell.
That's what we're saying though, if there's no signature that signs off that they've done that, then it's your word against theirs.
So I would say we're not going to actually, we're not going to solve this right now. But we'll take a subgroup here and work with some providers that we may suspect will not handle this well, and work with them to see what's going to work.
Well, you know, I've got a little bit of geeky information on that score. Earlier this year, the Journal of American Medical Informatics Association published an observational study, and the average time it takes to make a documentation for your physician is 10 minutes. And that includes at least 4 forays when in an EHR environment into different areas to get critical information from them to be able to document their thing. If you guys are able to use a note that already has the 4 critical pieces of information, then they don't have to do it. So over time, they'll actually realize better documentation, which is going to protect them on a couple of levels from a liability perspective, and if they know that you're signing off on your own orders, essentially, because they're not signing or double signing on it, they could actually be investigated by MQAC for supporting the unlicensed practice of medical care. So, you know,
MQAC is.
Oh, I'm sorry.
It's okay. Go ahead and tell them.
Medical Quality Assurance Commission. It's the medical board that decides whether they have a license to practice or not. And, you know, so by your guys being able to come up with a consistent system that will actually save them time, they're going to protect themselves from a risk liability issue. They're going to protect themselves from a medical board standpoint. And it's also going to keep you guys knowing that you're safe as well.
What about orders? I sign my product orders all the time.
Facial expressions.
Tell me about that, a verbal order, or they put in orders? Right, so they're giving you a verbal and you're entering the order and you're signing it off.
Service orders.
Service orders. Provider's name is on it.
So the provider's already entered in the order and you're signing off?
Oh, no.
They're entering the order for the
There are
doctor.
very few doctors who get the service orders in, they get the verbal. And then the MA puts it in under the provider's name, and then it
But
gets
these
signed
are all
off.
the things that I.
And that happens in rapid.
But you know, this is a framework for people to think about how they're doing it.
So I'll speak to this because the service order is also part of the chart document and the provider signs off on that. Always.
No, not in
Not
lab
lab
visits.
visits.
The chart document?
The walk-in labs, the providers
Yeah.
don't wanna have to see every lab visit of every patient that came in to walk-in lab today. and
Oh, when they
do
haven't
not.
seen the provider.
No,
Wants to hear it.
no, but there is a set of standing
But-
orders for the
right.
patient to have a CPE. But there's also when the providers have put the orders in, but we still have to do the service for the blood draw as well. So
And
I
they told
mean,
us to do a separate.
and we
lab
sign those
visit.
off, the providers never see it, but it's under their name.
Right, they already ordered it to be done.
Sometimes.
They might have in a standing order, set
Right.
of orders for a
Well,
CPE.
it's not always standing orders.
Correct.
Sometimes we have to put it in, so I'll put it in,
No,
and I'll say, for Dr. Knowles, and then I sign it off, so it's Dr. Knowles.
But you're an
that signed
LPN.
it.
No, but
Well,
see, we
they
got
make it
MAs.
too.
My MAs do
So
this
like I'll have a
constantly
patient
for the
walk
patients
in,
that
I'll
come
have
in.
a physical
I have a boss that has to do
schedule.
it.
And our standard is from my providers at the Bonnie Lake location is the TSA, CMP, they got standard orders set, okay?
Right.
So a patient will walk in, I'll draw their blood, I'll throw the orders in, put whoever the doctor that's authorizing or whoever's gonna see that patient, and then I'll sign the orders off and the blood draw and sign the chart note with no off. So they won't
But
see
there's
it.
a
In that case, actually, what you just described was really more of an administrative situation.
Right.
As opposed to a standing order that says, if patient tells you, I feel X,
Oh, no.
then you get to choose between W, Y, or Z. That's not something you can do.
Yeah,
But if you
How
have
many
a
of you do that?
protocol for the types of tests
OB
that need to
meds.
occur for a specific type of an appointment, that's different. You're not making a clinical judgment. You're engaging efficiently in the steps that need to occur for the patient to be able
So
to
that's
have a
fine,
clinical.
because
That's okay. That's not really.
And that's a protocol?
That's really more of an administrative protocol. It's
Right.
not a clinical decision.
that's
So
correct.
when it
There's no
comes to
clinical decision
diagnosing,
made.
is that what it sounds like when it comes to like actual diagnosing something, that's when we're a no-go?
Right.
Yeah, absolutely.
So they can do that.
Well,
Yes, in a lab order,
yeah,
yes.
in a lab order.
Especially, I wouldn't want you to
You're
make,
not just pulling one out.
yeah, I wouldn't want you to make one up.
Right?
So when a girl.
Guys,
Okay,
hold on. Holly has the
So
floor.
when a girl comes in,
Okay.
missed her period, but she doesn't know when her period was supposed to be, so we do a quant. But Dr. McDonald's not there always, so I just say, okay, yeah, get a quant on her and see if she's pregnant.
That's not a clinical decision that's gonna affect anything. It's an evaluative tool, just like the lab test would be.
Yeah, so, you have a female who is past adolescence, reproductively viable, missed period triggers test. It's not that you are assessing any other clinical presentation making unique judgment.
You're not making a medical decision. You're just evaluating whether a lab test is appropriate. Lynette?
So we have a young mother calling in, her son has a fever of 101.5. They want to know, can they have Tylenol, and if so, how much? We have standing orders on to tell them, how much does your baby weigh, how old is your baby, how long have they had the fever, and this amount of Tylenol is fine to.
Right. That's the standing orders that we're being advised now are not
And
okay.
then we type in mom calls, this is what she was advised.
That's not okay?
It's
So
not
that
okay.
needs to go up to a nurse.
Or you can say, follow the directions on the bottle.
The directions on the bottom.
Really though, consider the potential. If you've got a mother with a baby who's had a high fever, and they get reassurance from you that taking Tylenol is okay, and then it turns out that it's meningitis and the child ends up suffering permanent neurological injury.
It wouldn't be from the Tylenol, though.
That's what she
No, it wouldn't.
It's for nasal fever.
But that's why
But that's what the mother was doing. The mother's relying on you to understand whether or not it's okay to do this. So even though on its surface it's really routine, the reality is that the potential downside is very high. And so that's why Washington State says, we want to make sure that licensed people do it.
But the way I'm understanding it though means, so if a woman calls
everybody please, I gotta hear
she's
this.
telling me she's in labor and giving me how many minutes they're apart, how often they're, I can't say go to L&D.
No, you can't.
Yeah, you should.
You can say, I'm not in a position to be able to talk you through this, you need to present.
Right. You need to get help at a higher level. That's what you're
Okay.
saying.
So if
That's
a person
okay.
calls, I can say if they're, I'm afraid they're having a heart attack and they've spelled out all those symptoms, I am perfectly okay to say get to the hospital.
Yes.
Yeah.
And I don't have to ask my doctor.
You do not.
Because I'm not clinical.
But do we have to have them sign off on that?
You know,
Does it-
it's probably going to be pretty important, and I can tell you we've seen plenty of paid claims on this too, for your docs to be aware that they called in with that kind of symptomology.
Sure.
So that if they get admitted or they get discharged for follow-up, they have a clue. I've got to say, it was in Eastern Washington, there was a situation where a patient had been that way. And so the person who called, who answered, and I don't remember if it was an LPN or an MA, quite honestly, but said, you know, it sounds like, you know, you're really concerned about your chest pain symptoms and don't hesitate to go to the hospital. I am going to give this message to your doctor, but if you are that concerned, don't hesitate to go. Okay, so they did. Woman went to the emergency room, got worked up. It ended up not being a cardiac. But in the course of all of this, they had a chest x-ray done. And there was kind of a suspicious area on that. And the doctor was never really sure what happened. He didn't follow up with the patient. Patient came back later and said, oh yeah, I ended up going to the hospital, and by the way, he didn't get a discharge report, ended up being a delayed diagnosis of a pretty serious cancer. But the issue is that there wasn't a consistent flow of information back and forth so that the doctor knew that the patient might have gone to the hospital and was able to follow up with the patient about that. You know, so
where's the liability in that?
the liability on that ended up being in not following up with a patient who had a known significant event. Had he followed up with the patient, he would have been.
How did you know the person had a significant event?
Because the significant event was they called the office.
So how did the office
When
do
the
that?
hospital
They just
discharges
said,
you, they say you need to make an appointment with your PCP, so it should be on the patient, you would think, to follow up and make their appointment with their PCP.
Well, you would think.
Okay.
I think
Right?
would think
So when
that-
it's the
All right.
hospital.
We're definitely not going to solve all of
But
this.
she's right. The initial phone call is what should have triggered a concern about follow-up.
They should review it like everyone.
I just don't want everybody running around the clinics trying to find the LPNs to tell somebody to go to the hospital. That's
No, you do not. You absolutely don't need to do that.
That
That's
would
the
not be
safest thing, but document that you've said that. Okay, that's the critical
Yes.
piece of this that I want you
We should
guys to do.
document everything that we
Yes,
say
we
to a
should.
patient.
Yes, we should. Thank you. One thing leading to the discharge, I just want to let you know that in about a week and a half to 2 weeks, we're going to be starting a pilot project in the referrals department, getting emergency room discharges from Good Sam. And so the discharge notices are going to start flowing back to the referral department. And then I have asked Joanne to review those and to see whether or not the patient requires follow-up, and then we're going to be scheduling those patients. So we're going to be able to close that loop. It's not from a hospital admission, but an emergency room admission.
Hospital admissions will hopefully be
Yeah.
soon following. They don't come across electronically, and there is no, well, they don't come across 100% of the time, and they don't come across electronically. And there is no, we currently don't necessarily look and ensure that those patients are scheduled if they were advised to be scheduled, and make sure that that information is getting to the PCP.
So you
we'll be
may see
closing
those
that
start
loop.
flowing to you from Joanne when she reviews. She'll flow that to the team for scheduling. Okay.
What's the ideal time for the hospital ER docs to sign off on their chart notes so that it could be viewed by our practice?
It's supposed to be within 24 hours.
24 hours, I believe, is what.
It's not
I know.
happening.
We know that that's not happening yet. And we know that, and we're going to be able to actually have an exact number of those for you based on how it's going to start flowing into Clarity. So.
And then is this going to help with the patients that are being sent over as possible new patients for us that our providers aren't even seeing at the hospital?
What do you mean, so is it gonna help?
Well, because is it going to be able to catch them? The hospital's putting in providers' names of ours and they aren't even seeing the patients.
They might be being told that by the patient.
Not in this
So
case.
we don't know how that's happening. That
Is
would be
that
something
new?
for us to.
No, it's been an ongoing problem with Good Sam.
Who's making appointments?
I've had a patient come in with their discharge.
From a
Ladies,
hospital or the
ladies,
emergency
gentlemen.
room?
From the emergency room, and it had a date and everything already and a
Okay,
time
well-
on
But
it.
that's a one type thing.
That was one time, but the patient wasn't even on our schedule, but yet they went to the hospital. We took
I can say that we are in discussions with the hospital as a part of this pilot, us and some of you, that they will be sending patients that are not our patients. And so that's why I asked, is it a new thing or has it been ongoing?
It's ongoing.
But we need to assess kind of, what the payer is and all of that. Those are discussions that we have not completed yet.
Okay. Well, before I walk away, thank you for not